Okay, let's start. First group. Thank you.
Okay, good morning, Doc, and good morning, classmates. So
Afternoon,
we
eh.
are, ay, good
Afternoon.
afternoon. Sorry, Doc, wrong time zone. Oh, good afternoon. So we are the groups 1, 2, 3, and 4 from section A, and we're going to start our big group discussion now. Oh, wait. Okay, so case one, a 20-year-old factory worker comes in your clinic for a routine physical exam and gives you the following hepatitis panel results: HBS antigen positive, anti-HBS negative, total anti-HBC positive, IgM anti-HBC negative, and HBe antigen positive. So for the differential diagnosis,
Good afternoon, everyone. So for the first differential diagnosis, we considered inactive chronic HBV infection. So first on the screen, we have a positive HBS antigen and a negative anti-HBS antibodies, which means that the body was not able to produce anti-HBS antibodies. This indicates evidence of the HBV infection. And if the HBS antigen is present for more than 6 months, it may indicate a viral persistence and implies chronic infection. Now, next, we have a positive total anti-HBS antibodies, which indicates a previous or ongoing HBV infection. And this has a subtype, which is the IgM anti-HBS antibodies, which is a indicator, or it is a detectable only during a acute or recent infection of the HBV. So here it is negative, so it indicates a chronic infection. So next slide, please. So next, we have a negative HBe antigen and a positive anti-HBe antibodies. So this one is the hallmark for inactive carrier state or inactive chronic HBV infection. So what happens here is that anti-HBe antibodies are formed, so HBe antigen becomes undetectable. So there is a conversion from the HBe antigen positive to the HBe antigen negative. So it indicates an inactive HBV infection. This is also associated with the low levels of viremia or decreased presence of virus at the blood, and also low-grade liver inflammation. And then lastly, negative HBe antigen. So this implies no viral replication, or there is no viral infectivity, or usually patients are less infectious because there is a good immune response to the virus. So next slide, please.
Okay, for the differential diagnosis for number 2, we have active HCV infection. So as you can see on the screen, we have 3 hepatitis markers. So these 3 indicates a positive result that would lead us to have an active case of hepatitis C. So we have anti-HCV, RIVA, HCVA, RNA. And for us to have a major diagnostic to identify hepatitis C, the clinical markers will be the most important will be the anti-HCV. Thank you. Next.
So for this slide for the chronic HDV infection, we can say that this case is a super infection from the hepatitis B, since um, the presence of the absence of the HB antigen, and also we can say that this is chronic because of the um, absence of the IgM in anti-HBC and the presence of the IgG anti-HDV.
So our final diagnosis for this case is, next slide please, active chronic HBV infection. chronic hepatitis B infection. Based on the hepatitis panel result of the patient, the hepatitis B surface antigen is positive, thus indicating there's a hepatitis B infection. Then the anti-HBs, which is the antibody to HBs antigen, is negative, indicating no immunity to the hepatitis B. Then the total anti-HBC is positive, which is the antibody to hepatitis core antigen, indicating if the infection is either acute or chronic. And the IgM anti-HBC indicates acute or recent infection is negative. Thus, we can say that this isn't recent infection. Thus, it's chronic. And the last is the hepatitis envelope antigen is positive, indicating the active viral replication.
For the pathophysiology, next please. So seen here is the process by which the hepatitis B virus replicates. So the process is simplified into 6 steps. So first step is the attachment of the virus. So the virus enters the cell using endocytosis by binding to the receptors of the surface of the host cell. Next is by penetration. So the viral membrane merges with the host cell membrane. Now this sends its DNA and several proteins into the host cell cytoplasm. Next is the uncoating. Unlike other viruses, hepatitis B virus uses RNA to replicate. So hepatitis B virus is a partially double-stranded DNA that must be made into fully double-stranded DNA first. So next step is the replication. So the largest of the mRNA produced is used to make new copies of the genetic material. Fifth step is the assembly. So the mRNA are reprocessed, forming progeny variants that are returned to the nucleus, where they are recycled and make additional variants. So next step is the release. So DNA is synthesized via the reverse transcriptase, and new virus is sent into the cytoplasm, then towards the cell membrane where it is released. So because hepatocytes are continually proliferating, the virus is constantly being shed into the blood. Now, this contributes to the chronic infection seen here. Next slide, please. So here is a flowchart of the infection. First, the hepatitis B virus enters the cells of the liver, causing invasion and damage to hepatocytes. So the presence of the virus activates the immune response, causing liver inflammation. So this is seen in the patient as right upper quadrant pain and tenderness. Now, if the infection is prolonged or severe, inflammation becomes systemic, causing fever, nausea, and vomiting. Now, due to the immune response and release of inflammatory cytokines, there will be lysis of hepatocytes, leading to the release of its cellular contents. Now, this is responsible for the increased serum ALT and AST, which is seen in patients with hepatitis. So, majority of the infections is acute and usually will resolve over time on its own, and symptoms will improve. So, however, the infection is chronic, it would persist over time, and additional symptoms may develop. The progression of the infection would lead to decreased metabolic activity, decreased synthesis of plasma proteins, decreased bilirubin clearance, which in turn decrease serum glucose, decrease albumin, and increase INR, and jaundice. Now, further progression would lead to liver function deterioration and possibly end in cirrhosis, so leading to its different complications shown here. Then next, please.
So for the treatment and management, next slide please. The overall treatment goal in chronic hepatitis B is to prevent further disease progression and liver cirrhosis, and to reduce the risk of hepatocellular carcinoma. The risk of transmission, reactivation, and extrahepatic manifestations is also decreased by treatment, and the quality of life may be improved.
So for the pharmacologic therapy. So the first line of therapy is the pegylated interferon and antiviral agents under the class of nucleoside analogs, which are the entecavir or tenofovir. So first is the antiviral agents under the class of oral nucleoside analogs. So the example of these are the lamivudine, adefovir, entecavir, telbivudine, and tenofovir. They require long-term therapy in most patients. And when used alone, lamivudine and telbivudine foster the emergence of viral mutations. And also, they are very well tolerated. No cumbersome lab monitoring is required. Then the action of oral nucleoside analogs is that they inhibit the synthesis of DNA. Thus, it suppresses the hepatitis B virus DNA more profoundly than the pegylated interferon. Then it is effective in patients who fail to respond to interferon-based therapy. Next slide, please. The next is the pegylated interferon. It has a finite duration of the therapy. It achieves the highest rate of HBe antigen viruses after a year of support the viral mutations. It is poorly tolerated, so it requires more intensive clinical and laboratory monitoring. It requires subcutaneous injections, thus it is associated with inconvenience. The next is the combination therapy. The combination therapy is the combination of the nucleoside analogs and the pegylated interferon. The nucleoside analog being used here is the lamivudine in combination with the pegylated interferon. So it suppresses the hepatitis B virus DNA more profoundly during therapy than monotherapy. It is much less likely to be associated with lamivudine resistance. Then this combination used for a year is no better than a year of pegylated interferon in achieving sustained responses. Then in the combination therapy, it has a differential antiviral actions that may increase the likelihood of serologic responses and sustained response after treatment cessations. Then in here, as we can see in the chart, it features the different nucleoside analogs and the pegylated interferon having its route of administration, the duration of therapy, and the tolerability. So that would be all. Thank you.
So these are the specific treatment goals. First, undetectable HBV DNA in serum, as well as normal ALT, undetectable HBe antigen if HBe antigen was detected before treatment, and undetectable HBs antigen. Next slide. For the treatment response and cure, suppression of viral replication, undetectable or low levels of HBV DNA in serum, and normalization of ALT. For a functional cure, undetectable HBV DNA and HBs antigen in serum with or without anti-HBs seroconversion. Already present liver damage may partly regress. However, even in cases where functional cure is achieved, intrahepatic CCC DNA and integrated HBV DNA will remain. For virological cure, functional cure and eradication of intrahepatic CCC DNA, it is expected to eliminate the risk of reactivation of hepatitis B. For the complete cure, virological cure and eradication of intrahepatic integrated DNA. This can probably further reduce the risk of hepatocellular carcinoma.
For the prognosis, next slide. So severe acute hepatitis B can occur in a small number of cases and can sometimes be fatal. In most cases of acute hepatitis B, people recover completely after the short-term infection. However, a small percentage of patients go on to develop chronic hepatitis B. In people with chronic hepatitis B, the outlook depends upon the severity of liver inflammation, the amount of scarring, and response to antiviral treatment. People with mild liver damage who have no virus detected in the blood have a better prognosis. And about 20% of who develop long-term infection will develop liver disease and suffer from scarring or cirrhosis of the liver. And around 10% of those who develop cirrhosis will go on to develop liver cancer. And that ends our report. Thank you.
How about the answers to the guide questions? I think there's a question on there are two possible interpretations about this case. Ano man siya? Anti-HBe positive, no? So that is, you're correct. It can be inactive in the form of carrier. But take note, we are already in the chronic phase. So which particular phase in the chronic? So what are the four phases? What are the four phases in chronic hepatitis? You have immune tolerance, no, where the liver, the hepatocytes there's no inflammation yet. Okay, do not react. And for the second one is immune clearance, where there is increase in SGPT. Okay. And next you have lowering, so relatively lower amount of DNA. Okay, there's clearing, no clearing, immune clearance. The next is you have still a positive HBE, so still infectious. However, in the next phase, the carrier phase, you will have seroconversion. So there will be negative already in HBE, but positive in the antibody HBE. Then inflammation-wise, it's lesser inflammation. DNA count is lesser ba to? Basta, I forgot what's the DNA count. The next is the reactivation phase, wherein you have rising SGPT. Despite of a negative HBE, you have rising DNA and rising SGPT. No? Okay, so kana silang upat ka phase. So what's the answer for number one? The answer for differential diagnosis, kay you're given take note ha. In the case you're given the result naman, no? The patient comes in your clinic and you're given a result. So exclude ng hepatitis C and D, because what you're given is the result itself, no? And is the patient symptomatic or asymptomatic? Jaundice ba siya? Fever? Can you go back to the first slide, to the history?
Not mentioned.
Not mentioned, no? So the doctor, you're just presented with a hepatitis panel result. So ang sa panel is hepatitis B man. So number one, it's sure hepatitis B, pero what is it, acute or chronic? So for the differential diagnosis, I'd like to correct lang. You can have your possible answers for differential diagnosis. You can have acute hepatitis B, then rule out lang because of this IgM negative. Okay, rule out because of IgM negative. Then chronic hepatitis B, carrier phase, rule in. Chronic hepatitis B, reactivation phase, still rule in, diba? So how will you rule out? So the answer for the second question is, second question, what are the possible interpretation for this? So it's either you have a carrier, which most of the time, kay patient is asymptomatic man, no? So this is a possibly carrier phase or a reactivation phase. So how would you confirm? So you get the ALT or your SGPT SGPT and your DNA levels, no? If you want ultrasound pag yun, di ba? Ana. So, mana siya. I think what's the last question gali ani? 3 questions man siya. Ana. So, any questions? Any questions about this case? So, do you know how to interpret already? So, when you have a positive HBs antigen, what's the meaning?
Currently infected.
Okay, currently infected. Pero does it tell us with a positive HBs, does it tell us that the patient is infectious or having replication, active replication of the virus? Wala pa, no. We still have to see the HBE. HBE is positive. So that means patient is infectious. So lain man ang natakdan o makatakod, no? Do you get what I mean? Natakdan siya, pero makatakod ba siya?
Yes,
We just have to check for HBE. Okay? Then next is it acute or chronic? So we weren't given a chance to ask the patient, so how long this is, or when was the first time the HBS was obtained, wala man. So we just have to rely on the results, and the results showed us that we have a negative IgM. So negative IgM, more or less, this is a chronic case, no? So kana. So chronic hepatitis B, either carrier phase or your reactivation phase. Okay? Ana lang class, no? Sige, so question. A patient who is in a carrier phase is asymptomatic, no? You cannot tell that the patient is infected with hepatitis B because patient is asymptomatic. No other symptoms, no symptoms, no symptoms. Does the patient need uh, monitoring of the hepatitis panel? Yes or no?
Yes, Doc.
Ha?
I think
Yan?
needed niya i-monitor, Doc. That is because, Doc, ay naman siya possibility makatakod, Doc.
Yeah, the question is kung makatakod or dili, ano siya, patient is already negative for HBE. So at this phase, carrier, patient is not anymore infectious, no? HBE negative naman siya. Pero what's the more feared scenario? It's the reactivation phase. In the reactivation phase, even though if the patient is having a negative for HBE, negative HBE man na siya, and positive for anti-HBE in the reactivation phase, the DNA will rise up again. So dili na siya, it's not at that time the DNA is not the HBE is not anymore an indicator of the number of DNA. No? Kaya, di ba, usually before when the patient is when the patient has a very high count of DNA, HBV DNA, then we can just use your HBE, no, as an indicator of active replication. But in except in the case of reactivation phase, wherein you have negative HBE, but you have higher counts already of going back higher counts of DNA. Usaka siya balik, maski pa nga HBE negative siya, no? So mana siyang exception. Klaro ra, Clyde? Yan.
Yes, Doc. Mas nakasabot na ko, Doc. Thank you.
Yeah. So the answer for that is the possibility of conversion to reactivation phase, which is more dangerous. A patient at reactivation phase is infectious despite of negative HBE. Okay, sige. So, di ba, there's a part in the question na I'd like you to locate where it is, no? Basta it's, when we go back to that diagram, make sure the diagram is a chronic hepatitis B, no? And the part where you have this antibodies to HB already, that's either carrier or reactivation phase. No? Okay, sige, next group. Thank you, group. First big group. Let's give them a round of applause. Next.
So good afternoon, Doc. Good afternoon, everyone. We are the groups 5, 6, and 7, and we are going to present case number 3. Next, please. So a 28-year-old female prostitute visits the City Health Department for issuance of a health card. Due to limited resources, only 2 markers were ordered with the following results. So hepatitis B surface antigen and hepatitis B surface antibody are both negative.
So for the history and the salient features, the patient is a female prostitute and is 28 years old. The patient shows both negative for HBsAg and for anti-HBs. Next slide, please. So for further discussion, HBsAg or hepatitis B surface antigen. So an indication of positive or reactive HBsAg test results means that the person is infected with hepatitis B. So this test can detect the actual presence of the hepatitis B virus, or what we call the surface antigen, in the blood. If a person tests positive, then further testing is needed to determine if this is a new or acute infection or a chronic hepatitis B infection. This also means that if positive, it also means that you're infected and can spread the virus to others through your blood. So for our anti-HBs or HBsAg, or what we called as hepatitis B surface antibody, so a positive or reactive result indicates that a person is protected against the hepatitis B virus. This protection can be the result of the receiving of the hepatitis B vaccine or successfully recovering from past hepatitis B infection. This test is not routinely included in the blood bank screenings. So a positive result means that you are immune and protected against the virus and cannot be infected. So you are not infected and you cannot spread the hepatitis B to others.
Give at least 3 possible scenarios with this result. Mention other tasks that can be done to further investigate this case. 1 is immunological window period. HBs antigen disappears rapidly without the appearance of HB surface antibodies. This is the immunological window period, which the only evidence of acute infection with HBV is the IgM antibody. HBs antigen is detectable from 1 week to 10 weeks after contact. 2. Chronic HBV infection with undetectable HBs antigen levels. The patient could be one of the uncommon individuals with active HBV replication who is negative for HBs antigen. This is diagnosed when there is a positive HBe antigen or a positive HBV DNA result. 3. Remote resolved HBV infection with undetectable anti-HBs. The resolution of acute hepatitis is characterized by the disappearance of HBs antigen, appearance of anti-HBs, anti-HBC IgG, and normalization of ALT levels.
So these are the additional tests or markers ordered as tools to detect the disease process. First is HBeAg. This is a viral protein made by the hepatitis B virus and is released from the infected liver cells into the blood. This test detects how many viruses in the blood as a result of very active viral replication. So this appears shortly after HBsAg. Next is anti-HBe. This is made in response to hepatitis B E antigen. And this indicates that the patient is recovering from the HBV infection. Next is anti-HBC IgM or anti-HBC IgG. This is to clarify if the patient has acute or chronic infection. Anti-HBC IgM is the first antibody formed against HBsAg and is an indicator of current or recent acute infection. This is also present during the core window period. Anti-HBC IgG is, meanwhile, anti-HBC IgG is also present in all chronic infections. Hepatitis B, drug resistance genotype, and BCP pre-core mutation is used to detect a viral mutation that may be associated with resistance to treatments. Aside from these markers, there are also lab tests ordered to further evaluate liver function, such as alanine aminotransferase or ALT, which is found almost exclusively in the liver and is monitored closely in a chronic hepatitis B infection. Aspartate aminotransferase or AST is often ordered to help monitor potential liver damage from the hepatitis B virus. Next, please. Alpha-fetoprotein or AFP is used to screen for primary liver cancer patients with chronic hepatitis B. Ferritin is in a high level can indicate liver damage since ferritin is leaked into the bloodstream as liver cells are injured by the virus. Prothrombin time is used to assess liver disease. A high PT level means the liver is not making enough blood clotting proteins, and it usually means that there is serious liver damage or cirrhosis. And lastly, HBV DNA. It is useful in determining the status of chronic HBV infection by differentiating between active and inactive disease states.
So for the differential diagnosis, we have here acute hepatitis B infection in core window, chronic hepatitis B infection, and your HIV. So according to the salient features, the following features are: the patient is female, she is a prostitute or a sex worker. Also, it was read in the case that the patient had negative hepatitis B surface antibodies and hepatitis B surface antigen. So for first feature is for the female. So all of them have equal risk. These diseases have equal risk of activity for both gender. Also for the second feature, which is the sex worker or the prostitute. So according to Robbins, unprotected sex, such as those that have a jobs of being a prostitute or commercial sex workers, also those having intravenous drug abuse, are the chief modes of spread of this disease. So next is for the following test, your hepatitis B surface antibody and hepatitis B surface antigen. So for your acute HBV in core window, usually the results yields negative, and while as your chronic HBV, your Hep B surface antigen is positive, and your Hep B surface antibody is negative. So for your HIV, both yields negative results. So next slide, please. So for this, the following question: locate the window period and hepatitis B serological time course attached. So for our case, acute HBV infection in core window, the window period is found here, depicting 3 to 6 months. So in your convalescent window, as you can see here, there is a negative Hep B surface antigen and Hep B surface antibody, because in your convalescent window or in your core window, only your HBC IgM is the serological marker of HBV infection during this window. So there is usually this appearance of your Hep B surface antigen and Hep B surface antibody. Thus, HBC IgM is usually regarded as a marker of acute HBV infection in this window. So next slide, please. So for the final diagnosis, we have ruled in here acute hepatitis B infection in core window or convalescent window. So hepatitis B infection is the most common serious liver infection in the world, which is caused by your hepatitis B virus that attacks and injures the liver. So according to Robbins, 1/3 of the world's population, or 2 billion people, have been infected with HBV, and 400 million people have chronic type of infection with this virus. So our basis for the diagnosis of acute hepatitis B infection in core window is that the primary route of spread or spread of infection of this virus is through unprotected sex and intravenous drug abuse, so such as those sharing of needles and syringes. So these are the chief modes of spread. And also, having said in the case earlier that the patient is a commercial sex worker, this puts her in a high risk activity for acquiring the infection. And also in your core window, it is your results for your Hep B surface antigen and Hep B surface antibody should be negative, and as what have been read earlier, the results of the patient both for the following tests yielded negative results. So next, please. So here is another diagram to show your hepatitis B serology. So as what you can see here, the markers HBC antibodies, hepatitis B surface antigen, and hepatitis B surface antibody. So in your acute infection, there is positive Hep B antigen and negative Hep B antibodies, while in your window period, it shows here that both your Hep B antibodies and Hep B antigen is negative. So next, please.
Okay, so for the pathogenesis of the hepatitis B virus, this was already well discussed by the previous group, so I'll just be picking out some key points relevant to the case. So the entry of the virus starts with the different modes of transmission. So we have your sexual contact, which in this case is relevant to the patient as given that her job exposes her to high risks. And then another one is your contaminated blood, which is either through transfusion or injection, specifically the use of your intravenous drugs and the sharing of needles, as what the previous reporter had mentioned. And another route of transmission is through your childbirth. So mothers who are infected with hepatitis B virus could actually transfer this infection to their child. So upon the entry of the virus then reaches the bloodstream where it travels to the liver, and in the liver it invades the hepatocytes. So once this virus enters the hepatocytes, it actually makes use of the different organelles within the cell to allow itself to multiply and to undergo viral replication. So specifically, like it makes use of the nucleus within the hepatocyte to undergo transcription, and then it exits to the cytoplasm and undergoes translation. And in some cases, your core particles of this virus could proceed to going to your endoplasmic reticulum, where it is packed and turned into a vesicular transport vesicle, so that it could undergo exocytosis and then further infect other adjacent cells within the liver. So because of this ongoing infection, the hepatocyte itself can undergo an auto an apoptosis, or what we call your programmed cell death. So the hepatocyte itself can program itself to undergo cell death. At the same time, because there is an ongoing infection, your host immune response actually also takes in place. So a cascade of immune associated responses could also occur, and this would eventually lead to cell death as well. So because both your apoptosis and your host immune response lead to cell death, we can this is one of the reasons why we can say that your acute hepatitis B infection is actually self-limiting, because when the cells die, that the virus will also not be able to replicate and further expand its infection within the liver. Next slide, please.
So for the guide question number 3, how would you manage a patient in the question number 2? For the treatment, there's no medication recommended to treat the acute hepatitis B. But for the people with mild symptoms, healthcare providers usually recommend rest, adequate nutrition, and fluids. Infection usually resolves spontaneously. Should infection progress to a chronic condition, antiviral medications, interferon therapy, or liver transplant may be recommended. For the management, notification patient of results and prescription of treatment if only if needed. Collection of additional informations such as the reason for testing, previous exposure to HBV, and a complete medical history shall be done. Next, please. For the management, discuss testing for other sexually transmitted blood-borne infections and the need for help follow-up based on risk factors. The follow-up testing includes the HBsAg and anti-HBs 6 months after detection, or 3 months, most probably, to determine if the patient is a chronic carrier. If the case does not develop the anti-HBs at 6 months, the patient may still be in the window period of the disease. The case should be retested at 6 months intervals to assess the development of the anti-HBs while the HBs remains negative.
So for the prognosis of acute hepatitis B infection is generally good because, as previously mentioned, it is considered to be a self-limiting infection. So infection may last up to 6 months with or without the onset of symptoms, and the infected person is able to pass the virus to others during this time. Common symptoms that the patient may encounter or may manifest are the following. So we have the loss of appetite, joint and muscle pain, low-grade fever, and possible stomach pain. Now, most patients would probably be asymptomatic, while some will experience these common symptoms from 60 to 150 days after the infection. Some patients will also be able to manifest severe symptoms such as your nausea, vomiting, jaundice, or a bloated stomach that may cause or may lead for them to seek consult and admission. And these severe symptoms may also require treatment and management. Rarely, in some cases, your acute viral hepatitis B could result to a fulminant hepatitis, which occurs with a few new acute infections, and this would require immediate and urgent medical attention. This form of hepatitis could also lead to a sudden liver failure within days to a few weeks. And lastly, your acute hepatitis B could also progress to a chronic hepatitis, and this occurs in less than 5% of cases. However, some literature and other recent studies would say that there would be an increase in your chronic hepatitis B progression because of certain risk factors that may be different from one patient to another. And your chronic hepatitis B could also lead to a liver cirrhosis, and at some times, chronic hep B could also lead to liver cancer. That would be all. So these are the members of the group, and thank you for listening.
Okay, so yeah, you mentioned about the three scenarios now, but what is one possible scenario for a patient with a hepatitis panel result of, hindi mo siya panel, it's not panel because you're just given two parameters, no? HBS negative and anti-HBS negative. What is another possibility?
The patient is normal lang, Doc.
Okay, patient is normal. Very good, no? So the patient is probably normal, no? Because number one, negative man, so not infected, and also if the patient had not encountered any hepatitis virus in the past, then patient will not build antibodies towards will not build antibodies. So another possibility is the patient is normal, or that is what we call as false positive. No, false positive. So how are you going to do that? Minimum test requirement is the IgM, no? But if you want to be complete, you can have number one, the total antibody to the core. But if it's positive, then you still have to get the IgM, di ba? So IgM, and also your HBE, no? Your anti-HBE. No? If you follow the normal profile, no? And what else? Wala naman siguro. I think that's thoroughly discussed by your group. Okay, so any questions about the case? Any questions? So we are, most of the time, this is a case of window period, but other possibilities, you can have false positive or normal patient, or can have an AIDS patient, no, where you don't have sufficient antibodies, or negative for antibodies, or you may have a hepatitis B patient where, but you will have um, the patient will have deficient deficient HBS antigen. Mga special cases lang ni. Okay, but more often than not, this is a core window. Okay. Sige. So what will you do? You let the after the labs, you let the patient come back after another 3 months or 6 months. Okay, to check if the patient will already build up antibodies. So if the patient already has antibodies after 3 to 6 months, that means that the patient had been infected before. Okay, and make sure also that the patient did not have vaccination prior. Okay, that will distort, that will confuse us, man. Because if you give vaccination, then the antibodies might be secondary to the vaccination. Okay? Ano lang. Any questions, class? Any questions, clarifications? Sige. So let's proceed to the next group. Very good. Second group, BGD. BGD stands for big group discussion. Kaya tayo small, di ba? Parang big na po. Dapat large group man na siya. Pero I changed it to big group. Okay, so next group, take it away.
Good afternoon, everyone. In behalf of groups 1 to 4 of section C, I'm gonna present the case assigned to us, which we have diagnosed as inactive chronic hepatitis B infection. I am Nikolai Bilandres, by the way, and together with my group mates from group 1, we're gonna present our case. So a 25-year-old male farmer whose mother died of complications of active chronic hepatitis B presents with the following profile: positive for HBsAg, anti-HBC, anti-HBe, and negative for anti-HBs, anti-IgM, HBC, and HBeAg. So salient features, as mentioned, 25-year-old male farmer whose mother died of complications due to active chronic hepatitis B complications. So for our diagnosis, we diagnose the patient as having an inactive chronic HBV infection or in a carrier state. So we can see, we can see that the patient's results below coincides with that of the table as presented in our textbook. So chronic HBV carrier state, having a negative IgM of anti-HBC, positive total anti-HBC, positive for HBsAg, negative for anti-HBs, negative for HBAg, and a positive anti-HBe. So for carriers are, as defined by Robbins, are individuals who carry one of the viruses but have no liver disease, or those who harbor the virus and have non-progressive liver damage but are essentially free of symptoms or disability. And they are defined as an individual with positive HBsAg, anti-HBe, and a negative HBeAg. So what do the values in our case mean? So HBsAg indicates presence of infection. Anti-HBC indicates past or current infection. Anti-HBe indicates virus inactivity and low infectivity of the host. So those were the values that were positive in our case. Anti-HBs suggests cure or immunity, and it is negative in our case, indicating that the patient is not yet cured of the disease. IgM anti-HBC suggests recent infection, which is also negative in our case, suggesting that the patient has been infected with the virus for a considerable time already. HBeAg suggests replicative activity, and it is also negative in our case, suggesting that the virus in the patient has a low replicative activity. For the differentials, we tried to figure out whether the patient has an active or an inactive infection. But as what was discussed earlier, the patient has a positive HBsAg, anti-HBC, and a positive anti-HBe, suggesting that he has an inactive infection. Given the salient features, we can hypothesize that the patient was infected via vertical transmission. And according to studies, vertical transmission may happen in 3 distinct periods: during gestation, during delivery, or after delivery. And it most commonly happens here during delivery, wherein the neonate is exposed to the bodily secretions of the infected mother. And once infected, the body's immune response depends on the immune reaction. So in newborns, there is immune tolerance or absent immune response, which lasts for many years, leading to an inactive chronic infection, otherwise known as the carrier state. In this state, HBsAg is still detectable in the serum. For other acutely infected cases, the body may elicit immune response. A vigorous immune response to HBV leads to viral clearance, while an intermediate immune response produces chronic hepatitis. In the recovery state, the virus cannot be detected in the blood by DNA or HBsAg assays, and antibodies to the virus have been produced, especially anti-HBs. The final state of HBV disease is cirrhosis. Patients with chronic HBV infection are likely to develop hepatocellular carcinoma with or without cirrhosis. And for carriers, just like in our case, the virus may also reactivate, which also leads to this final state of HBV disease. So to wrap up the pathophysiology, the pathogenesis and clinical manifestations of HBV infection are due to the interaction of the virus and the host immune system. The immune system attacks the HBV and causes liver injury, the result of an immunologic reaction when activated CD4 and CD8 lymphocytes recognize various HBV-derived peptides on the surface of the hepatocytes. Impaired immune reactions or a relatively tolerant immune status result in chronic hepatitis. In particular, a restricted T-cell mediated lymphocytic response occurs against the HBV-infected hepatocytes.
So for your diagnostic modalities, it includes the liver-related blood test. So blood tests can detect signs of the hepatitis B virus in your body and tell you whether it's acute or chronic. So it includes the alanine transaminase test or your ALT, aspartate aminotransferase test or your AST, alpha fetoprotein, ferritin. Next is the liver function test for your albumin, bilirubin, alkaline phosphatase. Next is the liver ultrasound. So it is a special ultrasound called transient elastography, can show the amount of liver damage. Next is your liver biopsy. So it includes inserting a needle through your skin and into your liver and removes a tissue sample for your laboratory analysis. Next are your hepatitis B serologic markers. So there are around 6, which explained earlier. First is your hepatitis B surface antigen. So this is a protein on the surface of the hepatitis B virus. It can be detected in the serum during acute or chronic HPV infection. So the presence of hepatitis B surface antigen indicates that the person has hepatitis B infection. So this is the antigen used to make hepatitis B vaccine. Total hepatitis B core antibody. It appears at the onset of symptoms in acute hepatitis B infection and persists for life. So the presence of anti-HBC indicates previous or ongoing infection with HPV. Next is your IgM antibody to hepatitis B core antigen. So its presence usually indicates acute less than 6 months as opposed to chronic hepatitis B infection. Can also be found during viral reactivations. Next is your hepatitis B E antigen. So a product of the nucleocapsid gene of the hepatitis B virus that is found in the serum during acute and chronic hepatitis B infection. Its presence indicates that the virus is replicating and the infected person has high levels of HBV. However, patients that are HBeAg negative may also have high levels of HBV. Next is your hepatitis B-E antibody. So spontaneous conversion from E antigen to E antibody is a predictor of long-term clearance of HBV in patients undergoing antiviral therapy and indicates lower levels of HBV. Next, lastly is your hepatitis B surface antibody or your anti-HBs. So the presence of anti-HBs is generally interpreted as indicating recovery and immunity from HBV infection. So anti-HBs also develops in a person who has been successfully vaccinated against hepatitis B. So for your treatment, so most people diagnosed with chronic hepatitis B infection need treatment for the rest of their lives. Treatment helps reduce the risk of liver disease and prevents you from passing the infection to others. Treatment for chronic hepatitis B may include, number one is your antiviral medication. So these are the example, and entecavir or your beraclud, tenofovir, lamivudine, adefovir, and your telbivudine can help fight the virus and slow its ability to damage your liver. These drugs are taken orally. Next is your interferon injections. So interferon alpha 2B is a man-made version of substance produced by the body to fight infection. It's used mainly for young people with hepatitis B who wish to avoid long-term treatment or women who might want to get pregnant within a few years after completing a finite course of therapy. So interferon should not be used during pregnancy. Side effects may include nausea, vomiting, difficulty breathing, and depression. Next is your liver transplant. So if your liver has been severely damaged, a liver transplant may be an option. So during a liver transplant, the surgeon removes your damaged liver and replaces it with a healthy one. So most transplanted livers came from deceased donors, though a small number come from living donors who donate a portion of their livers. Next are your management. So management of chronic hepatitis B includes HBsAg monitoring to check for seroconversion throughout pegylated interferon and or antiviral treatment, routine blood tests at least annually to check liver enzymes, screen for possible hepatitis C infection, monitor for possible disease reactivation, and avoiding alcohol consumption and overuse of NSAIDs. So prognosis, most people with chronic hepatitis B should expect to live a long and healthy life. Positive prognostic factors, patients who have lost the hepatitis B e antigen and in whom hepatitis B virus DNA is undetectable have an improved clinical outcome as characterized by the following. First is your slower rate of disease progression, prolonged survival without complications, reduced rate of HCC and cirrhosis, clinical and biochemical improvement after decompensation. So according to Fatovich, prognosis and survival rate are the following. The estimated 5-year rates of progression, chronic hepatitis to cirrhosis is 10 to 20%, compensated cirrhosis to hepatic decompensation 20 to 30%, compensated cirrhosis to hepatocellular carcinoma is 5 to 15%. So the survival rates are compensated cirrhosis is 85% at 5 years. The compensated cirrhosis is 55 to 70% at 1 year and 50 to 35% at 5 years.
For the journal,
The title is Active Chronic Hepatitis B Increases the Risk of Colorectal Liver Metastasis, a retrospective cross-sectional study. Next. A considerable part of the colorectal cancer patients also have chronic hepatitis B, particularly in Asia. However, the effects of concomitant active chronic hepatitis B on the hazard of colorectal liver metastasis remains unclear. Thus, this study will evaluate the effect of concomitant active chronic hepatitis B on the risk of colorectal liver metastasis. For the methodology, a retrospective cross-sectional study of 7,187 newly diagnosed colorectal cancer patients in 3 hospitals was performed. The, the synchronous colorectal liver metastasis, which is a simultaneous diagnosis of liver metastasis together with primary colorectal cancer, was performed. In brief, all the patients with colorectal cancer underwent chest radiography and abdominal and pelvic ultrasonography. If these studies suggested possible pulmonary or hepatic lesions, CT scan was performed to confirm the diagnosis. All liver metastases were verified with CT scan that was reviewed independently by 2 senior radiotherapists. The study was divided in all the patients into different groups depending upon the status of HBsAg or HBeAg, baseline clinicopathological parameters, and the prevalence of synchronized of synchronized colorectal liver metastasis were compared between these groups. Then there's significant risk factors for synchronous colorectal liver metastasis were analyzed by first univariate logistic regression analysis and by multivariate logistic regression analysis. For the results, the overall prevalence of synchronous colorectal liver metastasis was 8.72%, and this was significantly higher in HBsAg positive patients compared with HBsAg negative patients. In univariate and multivariate logistic regression analysis, HBAg positivity was the second strongest predictor of synchronous colorectal liver metastasis after CEA. For the conclusion, HBAg positivity is a clinical risk factor for colorectal liver metastasis that can be readily identified and disposed. However, it is yet unclear if antiviral treatment can decrease the risk of liver metastasis in colorectal cancer patients. But future studies with carefully designed prospective trials will be needed to better define this.
Okay. So what are the 2 possible scenarios for this patient? Presented with the patient that is positive for HBE. So correct, no? Chronic, it's chronic hepatitis, but what are the possible scenarios? Kini. Either immune, both no chronic man kay IgM positive, IG total positive and negative man sa IgM. So this is a chronic case, either immune tolerance or immune clearance. Either way, murag nasayap ko sa first group, no? What was the result again sa first group? HBe positive to negative? John Clyde, in the first group, in your case, was that a positive or negative? Negative HBe or positive HBe? Hello? Hello? Naputol? Wala lang.
Positive. Positive.
Yeah. So this one, Tempamurg, ako ang na-confuse. Wait lang. Let me see. Anti-HBe positive. Sorry. So this one, this is a case of, ano siya, it's not immune clearance. It's either carrier or reactivation phase, ha? Okay, negative naman siya sa HBe. For the first case, positive ang HBe, right?
Yes, Doc.
So kung positive ang HBE, it is a case, it is a choice between immune clearance and immune tolerance. Immune tolerance or immune clearance, nalibog mo sa first case. I kaning sabi pa kung pag-recall ba, I interchange the result, no? So for the first case, the answer is it's either immune clearance or immune tolerance. For this case, since you are negative already in HBE, then it's a carrier or reactivation phase, right? Right? Agree? Do you agree? But this one, since you have the mother of this patient died of complications of active chronic hepatitis B, then it is most likely a carrier, carrier phase. Okay, take note ha sa first group ha na overlook na ko. I interchanged the both cases, no. Kindly take note lang ha. First group, this case and the first case. Okay, so any questions for the third group? Any questions? Do you know why that this is a case of a carrier? You don't have to refer to the table, no? Actually, you can interpret already based on the hepatitis markers. Okay, carrier siya because you have, number one, it's HBs positive. Number two, it's a chronic case, anti-HBC, no? Then anti-HBM, IgM negative, no? HBC IgM negative. So that means it's not an acute case. Then you have a positive already in your antibody to HBE. So another pertinent part of the history is patient had a mother who had hepatitis B also, vertical transmission. Okay. So how would you, it's a toss between, again, it can also, the patient may be in reactivation phase or will convert to a reactivation phase later, if the patient is not careful. Okay, thus monitoring is still needed. Okay, so how would you differentiate a carrier phase and a reactivation phase? You have to get the SGPT or ALT and the DNA. Okay. Same for the previous, same sa first case bitaw. Sa first case is either immune tolerance or immune clearance. How would you differentiate? It's again SGPT and DNA. Okay, so any questions? Any questions? Clear? It's clear already. So the purpose of these cases is for you to be able to interpret. Number one, interpret good, no? Ang location, this one, ang location ani is in the graph where you already see antibodies to HBE. Okay, antibodies to HBE tell you that the patient is not anymore infectious. But again, exception for the reactivation phase, because even though you have a negative, even though you have already what you call this a negative for HBE in the activation phase, again the DNA still will go back to higher levels. Okay? Klaro ra? Sige. Next group. Thank you so much. Thank you so much.
Good afternoon, Doc, and good afternoon, classmates. I will be reading the case on behalf of groups 5 to 7 of section C. And I would like to apologize in advance for the background noise because I have 20 pets. So you were able
Aircon?
to...
Aircon?
Huh?
What
I have
pets are?
20 pets, Doc.
Dogs?
17 cats, 2
Ah,
cockatoos, and 1 dog.
kuyawa. Sige,
And then
sige.
they're being noisy. So you were able to examine a 40-year-old carpenter as a requirement for renewal of his employment. His hepatitis profile results state that the hepatitis B surface antigen was positive. The total hepatitis B core antibody is positive. The immunoglobulin M antibody to hepatitis B core antigen is positive. HBeAg is positive. Anti-HBe is negative. Hepatitis B surface antibody is negative, and the HBV DNA is 200,000. Next, please.
Good afternoon, Doc. So I would be discussing about the salient features. So with regards to the purpose of these tests, it's already been mentioned in the previous cases, so this will be like a review. So the patient's hepatitis profile results are as follows. Sorry, excuse me. Okay, so the hepatitis B surface antigen is positive. So this tells us that the person's infected since this detects the presence of hepatitis B virus in the blood. The anti-HBC total is positive, which indicates that there has had been a previous or ongoing infection of the hepatitis B virus. And then the anti-HBC immunoglobulin is also positive. This indicates, excuse me, this indicates that there has been a recent infection with the hepatitis B virus, so around less than 6 months. And the presence of this indicates acute infection. Hepatitis BE antigen result is positive. In translation, there's active infection of the hepatitis B virus. So this is an indicator that the virus is actively multiplying, so viral replication. So this means that anyone who comes into contact with the patient's blood is at risk of getting infected. Anti-HBe showed to be negative. So ideally, you'd hope to see a positive result for this test because it means that the virus is inactive and not infective. But since in this patient's case, it's negative, that tells us that the virus is actually active and this patient can infect other people. Anti-HBs also shows negative, and again, ideally, we'd want it to be positive because a positive result would mean that there's immunity and that this patient is protected. But because it's negative, this means that he's not protected from the virus and can get infected. Lastly, we have the HBV DNA level, which is 200,000. And this is a marker of active hepatitis B virus replication. And this number shows or tells us that this patient is at an increased risk of developing hepatocellular carcinoma. And it could eventually, with progression of cirrhosis. That's all.
For the final diagnosis is acute hepatitis B infection. This virus causes infection of the liver with clinical features that are extremely variable, ranging from absent or mild disease to severe liver infection. It is also the most common serious liver infection. This can be transmitted primarily by body fluids, especially the serum. It is spread effectively by unprotected sex and can be transmitted from mother to baby. So for the basis, hepatitis B produces several protein antigens that can be detected in the serum. A core antigen, which is the HBC antigen, a surface antigen, which is the HBs antigen, and an E antigen, which is the HBe antigen. So for the basis, the patient's hepatitis profile results are positive with HBs antigen, anti-HBC total, anti-HBC IgM, HBE antigens. The table below is the interpretation of patterns of HBV markers, and the highlighted ones are the interpretation for acute HBV infection, which is the same positive interpretation with the patient's result. The initial serologic marker of acute infection is HBs antigen, which becomes detectable 2 to 3 months after infection. After another 4 to 6 weeks, IgM anti-HBC appears accompanied by increases in AST and ALT. When symptoms of hepatitis appear, most patients still have detectable HBs antigen, although a few patients have neither detectable HBs nor anti-HBs, leaving anti-HBC the only marker of infection, which is the core window. Next slide.
So for the differential diagnosis, based on our final diagnosis, which is acute hepatitis B infection with the patient's hepatitis profile results, we have our first differential diagnosis, the active chronic HBV infection. So we have a positive HBs AG, which indicates presence of hepatitis B infection, positive total anti-HBC, which indicates a previous or ongoing infection with hepatitis B virus, negative IgM anti-HBC, which indicates no recent infection with hepatitis B virus less than or equal to 6 months, then its presence indicates acute infection. Then a positive HB antigen and negative HB antibody usually indicate an active hepatitis B virus replication and high infectivity. The last one is negative hepatitis B surface antigen, which indicates no recovery and no immunity from hepatitis B virus infection. Thus, a positive HB SAG and positive anti-HBC, positive IgM anti-HBC, and negative anti-HBS indicates an acute infection, while a positive HBs AG, positive anti-HBC, negative IgM anti-HBC, and negative anti-HBS indicates a chronic infection. It is basically the presence of IgM anti-HBC in acute hepatitis B infection that rules it out from active chronic HBV infection.
For the second differential diagnosis, I chose recent resolving HBV infection. So, in contrast to acute hepatitis B infection, the HBsAg and HBeAg are negative in the recent resolving HBV infection, which indicates that there's ongoing infection. And since in recent resolving HBV infection, it's negative, based on the name itself, you can already say there's no more infection or it's resolving. And then anti-HBs and anti-HBe are negative in recent resolving HBV infection, which is opposite to acute hepatitis B infection, which is positive, because these signify that the body is already fighting the infection. So we therefore can rule out recent resolving HBV infection. Next, please.
For the pathophysiology, next slide, please. Before we discuss on the pathogenesis of the disease, let's first identify the viral genome that consists the hepatitis B virus. So the viral genome of your hepatitis B virus consists partially a double-stranded circular DNA molecule of 3,200 nucleotides that encodes the following 4 overlapping frames. These are your surface gene, core gene, X gene, and your polymerase gene. So your surface gene encodes the viral envelope. These envelopes are your glycoprotein, hepatitis B surface antigen, which is common to all hepatitis B, and it consists of 3 related proteins, the large, middle, and small HBS antigen. And infected hepatocytes are capable of synthesizing and secreting massive quantities of non-infective surface protein, mainly the small HBS antigen. And for the core gene, it encodes the core nucleocapsid protein and the E antigen. And the nucleocapsid core protein, which is your hepatitis B core antigen, and a longer polypeptide transcript with a pre-core and core region designated for your hepatitis BE antigen. And the pre-core region directs the secretion of the HBE antigen polypeptide, whereas your HB core antigen remains in the hepatocytes, where it participates in the assembly of complete virions. And for the X gene, it encodes the X protein. The HBX protein, which is necessary for the virus replication and may act as transcriptional transactivator of both viral genes and a subset of host genes. It has been implicated in the pathogenesis of hepatocellular carcinoma and HBV infection. And for your polymerase gene, it encodes a large protein promoting priming ribonucleic acid dependent and DNA dependent DNA polymerase and RNase H activities. So this replication of viral genomes occur via an immediate RNA template through a unique replication cycle, DNA to RNA to DNA. So next slide, please. For your antibody production, it was already mentioned in the previous slide. And then for your immune response, it is important because your host immune response to the virus is the main determinant of the outcome of the infection. The innate immune mechanism protects the host during the initial phases of the infection, and a strong response by the virus, specific CD4 plus and CD8 plus interferon gamma producing cell is associated with the resolution of the acute infection. The next slide, please. This was already mentioned in the previous report. I will just read this. For the pathogenesis, the incubation period is a very long, from 2 to 6 months after artificial inoculation of the infected blood and blood products. And the transmission is done either by parenteral way, sexual way, microtraumas, and transplacental way. And hepatitis B virus primarily interferes with the function of the liver by replicating in liver cells known as the hepatocytes. And the HBV virions, or your DANE particles, bind to the host cells via the pre-S domain of the viral surface antigen and are subsequently internalized by your endocytosis. And the pre-S and the IgA receptor are accused of this interaction. And HBV pre-S specific receptors are primarily expressed on hepatocytes. During the HBV infection, the host immune response causes both hepatocellular damage and viral clearance. And adaptive immune response, particularly your virus-specific cytotoxic T cells, lymphocytes, contributes to most of the liver injury associated with HBV infection by antiviral cytokines, because generally your HBV virus does not cause direct hepatocytes injury. Instead, injury is caused by your CD8 plus cytotoxic T cells attacking infected cells. And in the acute stage, there are signs of inflammation in the portal tracts, and the infiltrate is mainly lymphocytic. And in the liver parenchyma, infected hepatocytes show ballooning and form acidophilic bodies as they die. And next slide, please. The natural course of hepatitis virus can be followed by seromarkers. So here, in the incubation period, this stage will last approximately 2 to 4 weeks in healthy adults. And your HBs antigen appears before this, the red line, appears before the onset of the symptoms, peaks during overt disease 12 weeks, or it may persist in some individuals for as long as 24 weeks. And your HBe antigen, your HPV DNA, and DNA polymerase appear in serum soon after your HBs antigen, and all signifies active viral replication. And your HBe antigen, the appearance of the anti-HBe antibodies implies that an acute infection has peaked and is on the wane already. But persistence of your HBe antigen is an important indicator of continued viral replication, infectivity, and probable progression to chronic hepatitis. And your IgM anti-HBC antibody becomes detectable in serum shortly before the onset of symptoms, so in acute stage pa. So concurrent with the onset of elevated serum aminotransferase level. And over the periods of month, this IgM anti-HBC antibody is replaced by your IgG anti-HBC. So chronic stage na nandira na area. Then anti-HBs antibody does not rise until the acute disease is over and concomitant with the disappearance of the HBs antigen. Okay, next.
Next. So for the laboratory tests, following are the hepatitis B serologic marker. So first is the hepatitis B surface antigen, just what the other groups discussed. A positive or reactive hepatitis B surface test result means that the person is infected with hepatitis. So hepatitis B surface antigen is a protein on the surface of hepatitis B virus. So this can be detected in high levels in serum during acute or chronic hepatitis B virus infection. Always remember that if a person tests positive, then further testing is needed to determine if this is a new acute infection or a chronic hepatitis B infection. And also remember that a positive hepatitis B surface antigen test result means that you are infectious and can spread the hepatitis B virus to others through your blood. And also, hepatitis B surface antigen is an antigen used to make the hepatitis B vaccine. Next is the hepatitis B surface antibody. So the presence of the hepatitis B surface antibody is interpreted as which means that you are recovering or having an immunity from the hepatitis B virus infection. And if you are positive or reactive, this indicates that a person is protected against the hepatitis B virus. So the reason why a person is protected is because uh, the person is sorry, successfully recovering from a past hepatitis B infection, or he or she receives the hepatitis B vaccine. So that means you are not infected and you cannot spread the hepatitis B to others. Next is the uh, total, next is the hepatitis B core antibody. So if you are having a positive or reactive of the hepatitis B core antibody, it means that you have a previous or ongoing infection with the said hepatitis B virus infection in undefined time frame. So this hepatitis B core antibody, it will not provide any protection against the hepatitis B virus. So in order for us to fully understand the hepatitis B core antibody, we must first know the results of the first two tests that I'd mentioned, which is the hepatitis B surface antigen and the hepatitis B surface antibody. And next is the IgM antibody to hepatitis B core antigen. So if a person is positive with IgM antibody to hepatitis B core antigen, it means that the person has a recent infection with hepatitis B virus, which is less than 6 months. So it means that the patient has an acute infection of hepatitis B virus. Next is I will add is the hepatitis BE antigen. So this is a marker of having an active replication of the liver cells. So it means if you have a lot of this, is that it means you are having a more virus circulating in your blood. As a result, you are more infectious with a higher likelihood of transmitting the hepatitis B virus infection to the others. Next is the other tests are
Next, please. Okay, next is the liver ultrasound. This is the transient elastography that can show the amount of liver damage, and lastly is the liver biopsy. So which you need a small sample, only a small sample that is needed for your liver testing to check if you have any liver damage. That will be all. Thank you.
So for treatment and management, acute hepatitis B infection does not usually need specific treatment. So there are no medication available specifically for it, but may require treatment to relieve the symptoms. So usually doctors I recommend monitoring the patient's symptoms and getting regular blood tests to determine whether the virus is still in the body. And they also recommend to allow the body to rest, have proper nutrition, and drinking of plenty of fluids to help the body fight the infection. For patients who have abdominal pain, they can take over-the-counter pain reliever drugs such as ibuprofen. And in severe cases, patients can take prescription antiviral drugs or hospital stay in order to avoid potential liver damage and prevent further complications.
So in summary to what the other groups have wonderfully discussed, basically the prognosis of acute hepatitis B is good. Why? Because our patient is an adult in which they recover on their own fully, assuming that our patient has strong immune system since he's a carpenter. Also, the infection time takes 3 to 6 months with less harmful to no symptoms at all. And the infection have low probability of developing into chronic infection. However, if complications occur, it is treatable and manageable. Next, please.
So for guide question number 1, is there a reason for the patient to be alarmed? Why or why not? So yes, there is a reason for the patient should be alarmed because the patient has acquired acute hepatitis B infection. Not only that, but the results show that it's also actively replicating and contagious. So now, since the serologic markers have already been thoroughly discussed, I will just quickly run through. So the patient is positive for HBs antigen, which is the first marker to appear following HBV infection. Positivity indicates presence of a virus in the person's body. In acute infections, it disappears within 6 months, while with chronic infections, it persists for several years or sometimes even lifelong. Next, we have the anti-HBC total, which he tested positive, which is the most constant marker of infection. We have the anti-HBC IgM positive, which is a subclass of anti-HBC and observed during acute infection. It can also be used to differentiate between acute and chronic HBV infections. Next slide. So now we have the HBe antigen, which he's positive. It is produced in cells where virus is actively replicating and secreted into the plasma. Usually its presence indicates high viral load and high inactivity. Its absence indicates lower viral load, low HBV DNA level, and HBe antigen is associated with high risk of HBV transmission following exposure. He's negative for anti-HBe. Anti-HBe indicates host immunity response against HBe antigen. It is usually associated with reduced viral replication, lower HBV DNA, and reduced ineffectivity. He is negative for anti-HBs, which is the antibody for HBs antigen. It is a neutralizing antibody and confers protection from infection. It is not developed in those with chronic infections. It develops in response to hepatitis B vaccine, and its presence indicates immunity following the acute infection or vaccination. It persists for several years after infection, but it will disappear in a few years after immunization. Lastly, we have the HBV DNA at level of 200,000. It is a direct and accurate marker of HBV replication. Serum level seems to correlate with the risk of disease progression. It is used to decide for the need for antiviral drugs and can also be used to monitor efficacy of antiviral drug treatment.
Guide question number 2. Locate this event on the hepatitis B serological time course attached. So for acute hepatitis B, it is usually located where the HBe antigen, HBs antigen, and the IgM of anti-HBC meet. And based on the time course presented, it's from the part where the IgM of anti-HBC, which is the color violet, starts to rise until the part where the HBe antigen, the green one, goes down. So basically, that's the area where the normal time course of acute hepatitis B.
So for guide question number 3, would you allow this patient to work or not? So based on the patient's profile, he has active viral replication of hepatitis B virus as shown in the results of positive HBeAg. There is also the presence of HBsAg or surface antigen and a negative anti-HBs antibody, which signifies that acute infection is not yet over and the antibody is not detectable. So the patient is a carpenter in which the type of occupation is not a high risk of infecting others because it does not include food handling and other production-related job. However, patient may be suffering from acute hepatitis B, which, if not treated, will progress into chronic hepatitis and cause harmful effects on the patient's liver. So patient must be advised to temporarily stop working until his condition is addressed and must follow the proper protocol in the management of hepatitis B.
So for the journal, early predictors of acute hepatitis B progression to liver failure, author is Xiong et al., published July 26, 2018. So for the background and aims, 1 to 4% of acute hepatitis B cases in adults progresses to acute liver failure. The predictors of ALF and prognosis for patients with ALF are not clear. So this study investigated some of predictive and prognostic factors for AHB progression to ALF. So the results were the variables of age, anti-HBC IgM titers, HBeAg negativity, and total bilirubin at admission were significantly higher in ALF patients than in non-ALF patients. Compared to non-ALF patients, ALF patients had significantly lower values for prothrombin time activity, serum albumin, and HBV DNA. So for the conclusion, TB more than 5 by ULN and HBeAg negative status were the most effective and practicable factors distinguishing ALF from AHB at admission before the onset of encephalopathy. Peak PTA less than 20% and or HE grade 3 to 4 were independent predictors of a high probability of death or a need for transplantation.
So, any questions about the case? Okay, so with regards to the third question, will you allow the patient to work or not? You have as long as the patient is, because you have a case of acute infectious Hep B that is asymptomatic. The patient can be like that. As long as patient is not symptomatic, you can allow the patient to work. Okay, because the job is low risk. Okay, always constantly reminding the patient that he still is infectious even though asymptomatic. No? But if the patient is symptomatic, then advise the patient to rest. And okay, we also have this law, anti-discrimination law against hepatitis B patients. No, we should not discriminate workers who are positive for Hep B because they can still be productive. Ana, ana lang. ano siya, it's a political issue, no? It's a but it's there's a discrimination issue with this one. So yeah, would you allow the patient to work? Ideally, yes, but in the real setting, sometimes the employer is afraid to have someone who is happy positive, even if the job is low risk. Okay, so any questions? So you already know why this is a case of acute infectious, Hep B, okay, IgM positive, HBE positive. So in our exam on Monday, no, Monday naman day. So it can be like this. I will give you a Hep panel result, then interpret, or I will give you an interpretation, which is the possible hepatitis panel result. Okay. Any question, class? Any questions? So for the first group, ganyan, um, I made a mistake, no? So it should be ano siya, immune clearance and immune tolerance na siya. It's not carrier reactivation. That was a case of immune clearance and immune tolerance because HBE is still positive. Okay, any questions, class? So, announcement also, deadline for the worksheets, huh? For the GenPath worksheets this afternoon. You can help each other, but again, do not copy word for word. Of course, ayaw pasakop ba? Nga na lang. What else? And on Monday, clean path. I will give some pointers, but basically this is what I will post manpod later. What I just said prior, no, before. What else? Next week, you will also have a long exam, no, March 3, that will cover Dr. Lilia's topic, lymphoid, right? Lymphoid ba daw ang doc? Then GIT, Doc Alera, and my topic also liver. That will be 100 items. Okay, hapit na mag third bi-monthly, guys. So I hope naka-ipon na mo. Okay? So any questions? Any questions? John Clyde, no questions?
None, Doc.
None ra. Okay. So take note of the of the correction ganiya ha na nalibog ka I'm very postprandial sleepiness pa. Okay. Sige. So if there are no questions, then
Doc,
yes,
same question, Doc.
Unsa man?
Doc, if a patient is currently infected with hepatitis, is it okay matag immunoglobulin hepatitis?
Immunoglobulin hepatitis? Is patient is patient symptomatic? Asymptomatic?
Symptomatic or asymptomatic?
Symptomatic, better after na lang kanang wala siya symptoms, wala siya mga body malay. Okay, because you're giving antibodies man gyud, or you're giving actually duha man na siya. It's you know the Engerix, no? Engerix is the passive passive ba? No, it's the active there because you're giving an inactivated virus, no? So that the body will produce antibodies. Better yet, if the patient is asymptomatic, then vaccinate. No, vaccinate. Pero kung if the patient is symptomatic, better yet postpone the vaccination after na, pag later na when the patient is has recovered na of the symptoms na. Not really. Pwede ra ka mag-vaccinate. The general rule for vaccination is you do not vaccinate when the patient feels sick, no? Body malay, fever, example, jaundice, ayaw sa gid. Pero kung asymptomatic siya, then you can vaccinate.
Okay, thank you, Doc.
Okay. Any questions? Wala ra? Yeah. Kabalo ko ana. The questions will just pop out later now when you study. Right? For karon it's either maulog as or mahadlok. Ay kahadlok. We are all learning here. Okay. Sige class. So let's call it a day. Then wish you good luck and have a great day ahead. Thank you so much. I hope
Thank you, Doc. Enjoy.
Thank you,
Thank you,
Doc.
Doc.
Okay.
Thank you, Doc.
Okay.
Thank you, Doc.
Okay.